Hello and welcome to today's edition of Arizona Community Grand Rounds. My name is Mark Carroll and I serve as the Chief Medical Officer for the Medicaid Health Plans at Blue Cross Blue Shield of Arizona. I'm pleased to launch our first Arizona Community Grand Rounds for 2023. We have a great session in store for you today on long COVID with excellent panelists and discussants who we'll introduce in just a second. But before doing that, I'd just like to note that these rounds are co-sponsored and hosted by Blue Cross Blue Shield of Arizona and the NARBA Institute. We began the rounds as a collaboration back in 2020, shortly after the onset of the pandemic, as an opportunity for us to share timely information on emerging issues related to the pandemic, but also a number of other issues in healthcare and public health. To date, we've held over 25 Arizona Community Grand Round sessions, and recordings are available at a link that we'll provide for you later in today's session, or at least before the end of today's session. Thanks. I want to offer special thanks to my friend, colleague, mentor, Mary Jo Gregory, President and CEO of the NARBA Institute, who, along with colleagues at the NARBA Institute, have really provided excellent partnership and development of these rounds and today's session in particular. Some quick, brief administrative notes for today's session. All participant microphones are muted, but we invite you throughout the session. If you have any questions or comments you'd like to share, to please enter those into the Q&A. And our moderator will do a great job of getting to those at the appropriate time. And now we hope to provide continuing education credits for today's session. Special thanks to Carla Berg for her assistance in developing that for us. And a survey link and information about how to access those CEUs and complete information for us to help facilitate that will be available by the end of rounds. So now I'd like to introduce my colleague, Jessica Rigler, who serves as the Vice President for Population Health and Innovation at Blue Cross Blue Shield of Arizona, who will serve as our moderator for today's session. Jessica, thanks so much for leading our rounds today, and I'll turn it over to you.
Thank you so much, Dr. Carroll, and thank you all for being here. I'm really excited to dive into this session today. We've got a panel of excellent speakers, and I want to dive right into that. So first, I'll provide just a very brief summary of their impressive bios, and then we'll get going. First, it's my pleasure to introduce Dr. Sairam Parthasarathy. Dr. Parthasarathy is the Murray and Clara Walker Chair and the Chief of the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine at the University of Arizona College of Medicine, Tucson, and Banner University Medical Center, Tucson. He has a broad background in translational and clinical research with emphasis on intervention-based approaches in sleep, COVID, and health disparities, and is board certified in pulmonary, critical care, and sleep medicine. He practices at Banner University Medical Center in Tucson. Next, I'll welcome Dr. Bob Orenstein, who's a professor of medicine and a senior fellow in the Academy of Educational Excellence at the Mayo Clinic of Medicine and Science. He's been the chair of the Division of Infectious Diseases at Mayo Clinic since 2012, and is board certified in infectious diseases, internal medicine, and certified in travel medicine, as well as being a fellow of the Infectious Diseases Society of America. Dr. Orenstein practices infectious diseases at the Mayo Clinic Arizona Phoenix campus. He's the founder of the Mayo Clinic Microbial Restoration Therapeutics program and the C. diff treatment program. He's played a leadership role in organizing Mayo's response to both the COVID-19 and monkeypox public health emergencies. Dr. Orenstein is currently leading a CDC ADHS-sponsored emerging therapeutics consortium focused on health equity and improving education on emerging infections across the state. And finally, we're pleased to have Dr. Peter Rowe. Dr. Rowe is a professor of pediatrics in the Division of Adolescent and Young Adult Medicine at the Johns Hopkins University School of Medicine. His clinical and research interests for the last 30 years have focused on medical conditions characterized by chronic fatigue. His work has emphasized the importance of a variety of physiologic risk factors for chronic fatigue syndrome, including orthostatic intolerance, joint hypermobility, allergic inflammation, and adverse biomechanical strain. He's directed the Chronic Fatigue Clinic at the Johns Hopkins Children's Center since 1997. So now it's my pleasure to turn the floor over to these talented individuals to give some brief remarks. Please feel free to use the Q&A function to send questions our way. After each of our presenters provides his initial comments, we'll dive into all of the discussion. So with that, Dr. Parthasarathy, the floor is yours.
Thank you. Thanks so much for the introduction, and thanks for the invitation to be here. I was going to use some slides to just walk through my talking points, and I don't want it to go too long. So I just wanted to make sure that we sort of understand that there are two definitions of long COVID out there, and that the preferred term may be post-acute sequelae of coronavirus or COVID-19, but probably most ideally post-acute sequelae of coronavirus. That's because someone with a mildly, relatively low symptom load, asymptomatic presentation can also develop long COVID. And so long COVID is sort of the colloquial term, but then there are numerous other names that it's called in Europe and elsewhere. But I want to bring your attention to the two definitions. The WHO definition is that the symptoms should persist for at least 2 months in the 3 months following the onset of the acute infection. Whereas the US definition, which is the NIH definition, is that if the symptoms persist more than 4 weeks. So just wanted to draw that parallel. I'm part of the Recover Adult Cohort trial here, a study here, which is a $1.18 billion Biden administration investment into studying long COVID. And they purposefully kept this lower bar so that they can catch these people and see what the trajectories are and what would be outcomes-based definition of long COVID. This is pre-Omicron, where the ancestral strains and the Alpha, Delta were in play. And you can see that this meta-analysis suggests that the line drops onto about 43% down in the x-axis there. In 50 studies with millions of patients, you see that the number of, with 1.7 million cases, the number of people who have a long COVID is about 43%. And that translates to about, at that point in time, to about 153 million cases in the world. And so that's a ginormous number. And that's the burden and load that we are looking at. And there's also disparities based on populations, and there's also disparities of global disparities, where East Asian countries and Asian countries and Africa have a larger burden. So from a symptomatology, I was hoping to share with you some early findings in the Recover study. Fortunately, it's premature for me to be able to share. So instead, I'm sharing with you meta-analysis findings of the top 5 symptomatologies, which is fatigue, memory issues, dyspnea, sleep problems, and joint pain. And I wanted to show this slide in order to show that Arizona, the state of Arizona, is disproportionately affected. The shade of the green, the darker shades means there's a greater prevalence. And at this point in time, based on a pulse survey done in June 2022, at least, that snapshot showed that 7.5% of the population, not 7.5% of people who got COVID, 9.5% of the general population, as common as asthma and diabetes, is the condition of long COVID. Vaccinations helps not only acute COVID, but it also helps reduce the risk of long COVID. This is a JAMA paper coming from Italy. And you can see that the adjusted odds ratio, if someone got 3 vaccine doses in this fully adjusted model, it reduces the risk of developing long COVID by 84%. The nature of the Recover study sampling strategy is such that we may not see that kind of an effect, but there is still an effect. That's because it's been purposeful sampling done of cases and controls. And so those effect size that you will see in the Recover study may not be as large as this, but that's by design. So I just wanted to share with you what we did in the SEAL program, which is the NIH-funded Community Engaged Alliance to address the health disparities. I won't belabor the names, but I want to point out that this is a multi-institutional collaboration between the Mayo Clinic Scottsdale, ASU, NAU, AZ Chow, and the University of Arizona. And these are all the multiple PIs. John Tilbert has now replaced Chuck Devaney in Mayo Clinic. Otherwise, Sabrina Sterle and Sam Sabo are also multiple PIs. And these are the partners on the right side that spans the entire state that we are partnering with in phases in order to address initially acute COVID vaccination and prevention approaches, but now we are targeting these places for other reasons, which is essentially long COVID. The idea is to give trustworthy information to these populations, science-based information, through a culturally appropriate manner. And if this group knows the importance of that. We also did a needs assessment, disseminated the prevention practices, and addressed vaccine hesitancy and aimed to promote vaccine uptake. And I'll show a couple of slides on that. But in this slide, in terms of promoting inclusive participation of individuals who are disproportionately affected, we did it through a text platform, but also through the gold standard of community research, which is CHW's the partnership with AZ Chow. And we used the community to go to design the study. We'll see in the right bottom, there was a thought about, should we do randomized control trial, step-wedge cluster randomized trial, clustered by communities, or targeted statewide campaign? The community board told us you should be doing a targeted statewide campaign because it's unethical for you during the middle of the pandemic for you to be doing anything other than that. And so what I wanted to show you here is trustworthy source of information. This is a survey through the text platform in about 500 individuals. And you can see that the most trusted messenger is the physician and the doctor and the US COVID task force and the universities of Arizona. That's all of the universities of Arizona and the CDC. But then social media ranks the lowest, along with faith leaders or workmates and news sources. What I wanted to share with you is just this slide, this is actually undergoing review in the American Journal of Public Health. And this was essentially vaccine hesitancy based on vaccine type. What is shown, I want to draw your attention to the orange one, which shows that there was a marked difference in vaccine-specific hesitancy against the J&J vaccine, which was due to an April incident of blood clots, especially in middle-aged women. And so when that happened, you can see it takes about 8 to 9 months from when April, which is beyond the axis, and it takes until December for that information to permeate into Arizona communities. But you can see that they are changing, and their vaccine hesitancy, specifically to that vaccine, is reducing when compared to Pfizer or Moderna, which really didn't show much of a change. And we also are seeing race ethnicity differences, which may speak to some inherent biases. So we took to the air, we talked about the importance of vaccination during the acute pandemic time period. And right now we're working with physicians because they're trusted messengers in clinics in order to disseminate it. And there are 2 initiatives we're running right now, a provider education for anybody, any provider in Arizona, especially rural Arizona, who wants information about the latest research findings, as well as we're doing a patient-to-patient, peer-to-peer support group, which is addressing how to get disability, how to seek care in a long COVID excellence center, and how to participate in clinical trials. I'll stop right there and hand it off to Bob.
Thank you so much, Dr. Parthasarathy. Dr. Orenstein, I'd love to turn it over to you now for your comments. Thank you. You're on mute, I think, Dr. Orenstein. Dr. Orenstein?
Yeah.
Oh, there we go.
Sorry.
Thank you.
I was asked to talk about some potential therapeutics for long COVID that may or may not have some value in the future. So next slide. So just to give you an idea of what we're mostly focused on is 3 specific phenotypes of COVID-19 that cause long COVID: the neurologic phenotype, the respiratory phenotype, and then the cardiovascular phenotype. Next slide. So there have been a variety of hypotheses as to what causes long COVID. And some of these therapeutics that we're going to talk about are targeted at each of these potential mechanisms. So if you look at immune dysregulation, there would be some agents targeted at that. Microbiota dysbiosis, something near and dear to my heart that other people are looking at. Autoimmunity and potentially the impact of antibody production, blood clotting and microthrombi, and then some of the signaling abnormalities. Next. So as Sai pointed out to you, there's been some debate about the role of vaccination in long COVID and whether it reduces long COVID. Some of this data comes from a variety of long-term studies where people looked at those who had COVID and then received vaccination after, as well as those that got the vaccine prior to their illness. And all of these studies really do show that vaccines do do several things. One, they reduce the risk of developing COVID, which obviously by itself reduces the risk of long COVID. Secondly, they do seem to reduce the risk of long COVID by anywhere between 15 and about 40%, depending upon the studies that you look at. Interestingly, there have been a few small studies that have looked at antibody titers, and a couple of those have actually suggested that perhaps boosting antibody titers too much might actually cause some pathology and potentially make things worse. So I think this issue is still being sorted out as to whether there's value in the vaccine as a therapeutic for long COVID. We clearly know it's effective as a preventive measure. Next slide. So one of the studies that's been looked at for long COVID has been the COVID outpatient study. This is a study done by University of Minnesota and a variety of other centers where they looked at a variety of agents that were being used for treatment of COVID as well as long COVID, including ivermectin, fluvoxamine, and metformin, and looked at the long COVID outcomes. And it turns out that the data from this trial suggests that those patients that were on 2 weeks of metformin at a dose of up to 1,500 milligrams per day had a lower risk of developing long COVID, whereas those that got the fluvoxamine and high dose ivermectin, really there was no impact. So this is yet another study suggesting that there's really not much value of ivermectin in acute COVID. There doesn't seem to be much value of ivermectin in preventing COVID. And this study would suggest that there's not much value of ivermectin in preventing long COVID. But it does raise the possibility that metformin may play some form of immunomodulatory role in protecting people against long COVID. Next slide. So this just shows you in a graphical form the difference between the different groups, and the one that shows you the blinded control and metformin with a pretty wide separation, usually occurring around day 45 with respect to incidence of the 3 syndromes we talked about associated with long COVID symptoms. Next slide. The next one that has raised a lot of people's interest is the role of nirmatrelvir, ritonavir, or Paxlovid on long COVID. And there were a variety of small anecdotal reports suggesting that perhaps people treated with this drug did not develop long COVID. We know it's highly effective at preventing acute complications of COVID-19, hospitalization, and death. And the VA did a retrospective study looking at a large number of veterans who had received Paxlovid, comparing them to those who did not, and looking to see whether they developed any of the long COVID conditions. And this study suggested that there was about a 26% lower rate of long COVID developing in those individuals that received Paxlovid for treatment of COVID compared to those who did not. This is still not published. It remains in preprint form. So it'd be interesting to see what the analysis is when this is actually published. Next slide. So based upon this, Pfizer and Stanford have put together a study of Paxlovid given for 2 weeks to see whether there is a reduction in long COVID in those individuals that get Paxlovid versus the placebo arm. And this study is enrolling at Stanford currently. Next slide. What about brain fog? Obviously, this is a major issue for many people that have had COVID-19. Recent small uncontrolled trial published from a group at Yale looking at 12 patients showing that this agent, guanfacine, which is an alpha-2 adrenergic agonist, which has been used for other neurologic diseases, seemed to improve some of the quality and function in individuals that receive this. You know, I have to take this with a grain of salt. This is a very small study. It's uncontrolled. And I always don't put a lot of faith in studies published in journals such as neuroimmunology reports. If it was really something that was dramatic and everybody in the world needed to know about it, probably be published in a higher citation journal. Next number. Oh, next slide, sorry. This just shows you their proposed mechanism for how these agents might work, affecting some of the circuitry within the brain, controlling some of the calcium and potassium signaling channels. Next slide. Lastly, I wanted to mention a product that's moving into phase 2-3 trials from Excella. This is called AXA 1125. And this is essentially a combination of a variety of amino acids that suggested that perhaps it would improve overall fatigue and level of function. These amino acid compositions have been tried in a variety of other fatiguing illnesses, and NAC has been used for many years for fatigue. It was used early on in the HIV epidemic for some of the early symptoms there. The primary endpoint in this study was to look at this PCR outcome, which was thought to be a measure of mitochondrial function, but unfortunately the study did not meet the primary outcome measure. But when they did look at secondary outcome measures, such as ability to do the 6-minute walk and looking at some of the scoring based upon surveys, there did seem to be some significant improvement. And so when the FDA reviewed this, they did say it was okay for Excella to move on and do a phase 2, phase 3 trial. Obviously, these are relatively benign agents, and if they provide some benefit, that would obviously be valuable. Next slide. Lastly, I'll talk about some questionable practices. Bruce Patterson and his group, formerly from Stanford, have been promoting the in-cell diagnostic panel, which looks at a variety of cytokines. And their hypothesis is that a lot of what's driving long COVID complications is related to overburdens of cytokine release, particularly in monocytes that show persistence. And their group has been looking at agents that block CCR5. Initially, they were looking at a monoclonal antibody, and more recently, they patented the use of Maraviroc, which is a CCR5 blocking agent that we use in HIV infection to see if that reduced cytokines, as well as pravastatin, which is known to be a immunomodulator through the fractalkine inhibitor. And there are a variety of patients that you may have that have seen this online and may be looking into this. So I just wanted to mention this as something that that's currently out there. Thank you.
Thank you, Dr. Orenstein. That was great information for the group. I think we'll probably see some questions around that a little later on. But first, I'd love to turn it over to Dr. Rowe to provide comments. Thank you. Dr. Rowe.
Yeah, am I good?
Perfect. Yes, thank you.
All right, sorry. I'll be focusing on the experience we've had treating pre-pandemic ME/CFS because as we have been seeing young adults and adolescents who have a substantial impairment following usually a mild COVID-19 infection, these are not the patients who have been in the ICUs, that their clinical profile and their risk factors seem to be pretty much identical to the pre-pandemic patients, and they all satisfy the Institute of Medicine criteria for the diagnosis. So at a practical clinical level, one of the things that's really helpful in evaluating the severity of the impairment from long COVID is to focus on post-exertional malaise. So I'll talk a little bit about that in a minute. We have found over the last 3 decades that orthostatic intolerance is almost universal in the adolescents who have ME/CFS, and it affects about 90% of the adults. And the value of thinking about this in long COVID is that this form of physiologic dysfunction is one of the most treatable components in these prolonged illnesses. The last point I want to emphasize is that individuals with ME/CFS and long COVID have a non-random increase in the prevalence of a number of comorbid conditions. So these are not things that are occurring infrequently. We see about 60% of our patients having joint hypermobility. Many of them have postural dysfunctions when they're examined by physical therapists looking for adverse neural tension. A number have allergic inflammation or even mast cell activation. There's some preliminary evidence supporting the use of antihistamines and things that work on mast cells in the treatment. So each of these areas offers some potential inroads for us to improve function as clinicians, even when we don't have randomized trials available. So the Institute of Medicine criteria for ME/CFS were published in 2015. I was a member of the committee that produced this report. And what we emphasized is the core symptoms. These are the people who had 6 months of illness, and they had to have a substantial impairment in the activities that they tolerated before they got sick, usually accompanied by profound fatigue, but we put the emphasis on the impaired function rather than on the specific symptom of fatigue. The second core symptom was post-exertional malaise, the third unrefreshing sleep, and then they had to meet criteria for either cognitive impairment, which looks a lot like somebody suddenly acquiring ADHD, or orthostatic intolerance. Let me just mention about PEM. This is really a very important symptom to elicit in the history. These are patients who get an increase in a variety of symptoms after increased physical, cognitive, or orthostatic stress, and they can get this after a biomechanical strain. The symptoms include worse fatigue, but also other things like more brain fog, lightheadedness, headaches, and many symptoms that overlap with concussions. Patients know that this post-exertional malaise can extend well beyond 24 hours, and they refer to it as a crash. And while the symptoms may seem puzzling to clinicians, there are a number of gene expression changes that occur in the peripheral blood mononuclear cells in their expression of adrenergic, pain, and immune genes after exercise. So these changes correlate with what the patients are reporting as their symptom flares. And this is work from Alan and Kathleen White at the University of Utah. Our early experience with the adolescents and young adults who were meeting criteria for chronic fatigue syndrome after COVID infection was that all of them had orthostatic intolerance. So here's a 10-minute passive standing test in a young woman whose resting heart rate was 89 beats per minute. We had her standing, just leaning against the wall. And over that next 10 minutes, she got markedly more lightheaded. She got brain fog. She had an increase in her fatigue. And her heart rate eventually reached a peak of 166, just standing still. Some work from the Netherlands has really helped emphasize the importance of orthostatic intolerance. This is from Linda van Kampen and Frans Visser. They use a Doppler probe for about 30 seconds each on the internal carotid left and right and the vertebral artery left and right, so that they can add those flows up and get total cerebral blood inflow. And after 30 minutes on a 70-degree head-up tilt test, healthy people get a 7% reduction in their brain blood flow. But the CFS patients have a 26% on average reduction. So almost a fourfold greater reduction in brain blood flow, perhaps making it seem quite understandable that they have brain fog and lightheadedness. When they break down the overall group, 60% of them had a normal heart rate and blood pressure response to 30 minutes upright and might have been mistakenly told that they were fine, but they nonetheless had a 24% reduction in brain blood flow. The ones who had POTS or delayed orthostatic hypotension were a bit worse. They've extended this work to people with long COVID, and at the bottom you see the Doppler tracing of the left carotid artery showing the supine on the left and the upright flow on the right, and that's a healthy person who had an 8% reduction in brain blood flow in that vessel. Whereas at the top of the slide, you see a big reduction in flow in the long COVID patient who had a 39% reduction in flow when upright, really quite extraordinary. When they grouped their data, this was a small study of their first 10 patients with long COVID, all of whom met criteria for ME/CFS and all of whom had POTS, compared to people who'd been sick with ME/CFS for 5 to 10 years. You can see that the long COVID patients were even worse than the ones who had ME/CFS. And this argues against deconditioning as a major contributor, because the folks who were deconditioned would have been the ones who'd been sicker for longer. We use this diagram in our clinic to emphasize to people that even when they have orthostatic intolerance leading to ME/CFS or long COVID, they are coming into the illness with a variety of other comorbid features and genetic predispositions that affect the overall symptoms, but also provide us with an avenue into treatment. 30% of our patients have a delayed milk protein intolerance. Many of them have mast cell activation syndrome. We find that we can identify 80% having some kind of abnormality on the examination when they're gone over carefully by a good physical therapist. And that can include thoracic outlet syndrome, tightness in the legs and arms. Many have hyperhidrosis. There's a small subset who have neuroanatomic problems, so it's very important to do a careful neurologic exam. 60% meet criteria for joint hypermobility, and some have a variety of vascular problems. And anxiety and depression can be secondary phenomena when you're this impaired. I just want to end with a slide showing the patient whose standing test I showed you earlier. This is a woman with a PhD from Caltech who studies the mineral composition of the surface of Mars. The only way she can do her analyses is with this kind of setup at home, because when she's upright, she has so much brain fog due to the reduction in blood flow to the brain that she cannot calculate, she can't write and think. But she wants to work, and this is the setup she has at home. So I'm going to stop there and turn things back to Jessica.
Thank you so much, Dr. Rowe, and to all three of our presenters today. We're going to open this up for discussion, and as a reminder, you can add your questions or comments into the Q&A section. But before that, joining our three speakers today is Dr. Nick Staub from the Maricopa County Department of Public Health. I'd love for him to provide a little public health perspective to this conversation, as well as share information about a Project Echo for long COVID. Dr. Staub, if you would, please share regarding Project Echo, and then any initial thoughts that you have after hearing those remarks and how this relates to public health and the work that you all do.
Great. Thank you, Jessica. And thank you to the organizers for inviting me today. Public health certainly appreciates having this opportunity to engage with both providers in the community as well as everyone here in the audience. I think to that end, I wanted to briefly share my screen. So Maricopa County Department of Public Health, in coordination with partners at ASU, are going to be hosting a long COVID Echo series for healthcare providers in the community. This will, much in the same way that this Grand Rounds is doing, provide an opportunity to share information about long COVID to healthcare providers, as well as provide a case-based presentation on a variety of different themes related to long COVID. So it will be a 16-session program. The first session will begin on April 6th. And again, healthcare providers are invited to participate and learn more about long COVID through the series. We are pursuing CME credit for this series. I can't announce that just yet because we haven't finalized that, but we are working on that. So this flyer here and the registration link will be provided into the chat for you all to learn more about it. I will also share that link to the website so we can post it up in the chat. In terms of public health's response to long COVID and the way we're kind of addressing it, really the role of public health is still being explored in what we can do to help better understand long COVID. Really, there's no precedent with other disease states that public health monitors looking at kind of the long-term side effects of an illness. So we're very interested to work with partners, work with researchers, follow with our healthcare providers to better understand the impact of long COVID, not just on the individual level, but really in the broader community. To that end, really one of our roles is collecting data, analyzing that data and sharing it out with our partners. So that is really what we are most interested in doing and better understanding. I would be very interested to hear from any of our participants today really, what are the metrics? What are the data points that you would like to see from public health in order to best describe what the impact is of long COVID on our community? Those are, we've got lots of data out there. We're always analyzing it for other reasons. And so we really just want to kind of be able to pull that and share that back out with providers. One of our other roles in public health is getting out and talking to healthcare providers, making sure that they have the information and the resources they need to treat and help their patients. So again, a lot of resources were shared very quickly today. I saw a couple of questions come up already in the Q&A about how providers can get those resources. So again, public health will be pulling all that information together and kind of having a central repository for those resources for healthcare providers, as well as doing things like our long COVID echo. Really, in the end, what we're trying to do is better understand the burden of long COVID as we come out of the COVID pandemic, so that we can all be prepared to continue to meet the needs of our communities. I'll pause there, Jessica. Thank you.
Thank you so much, Dr. Staub. I would love to hear some feedback, though, from our panelists on the question that you posed related to how public health can lean in, what kind of data or metrics would be useful in helping to, from a public health perspective, and helping to inform the work that's happening on the clinical side on this topic.
Yeah, actually, one of the gaps, as I showed in my slide is that, when there's information that, for example, that there's a vaccine that may be associated with harm, it takes about 8-9 months for it to permeate into the community. If there's a car recall, or if there's a baby seat recall, it probably transmits faster. There's the issue about misinformation and disinformation as well. But there is the issue about how to transmit information. And relevant to long COVID is that there isn't a public health robust infrastructure that people think that is valued. If the doctors are the most trusted sources, then we need to get that information out through the doctors and through other trusted sources. And that's why these studies, which repeatedly keep showing those, I think the county health department needs to establish strong relationships there. And when we embed ourselves in these clinics to target high-risk patients for vaccination now, telling them it not only helps with acute COVID, but also with long COVID, there is an issue of uptake, because the primary care physician does that, but the specialist doesn't. But the specialist is the one who's seeing an enriched population of at-risk individuals. So I really think that there is a lacking infrastructure for dissemination of information statewide. And I think we're, in terms of, it's not a PSA, it's health literacy. I think a lot of people with long COVID don't know what is long COVID, or they have misunderstanding as to what long COVID is. And while we are trying to grapple how to define it, we need to come up with a definitional way of approaching that in terms of days after which the symptoms are still present. But there are a lot of people out there, from what we did in the peer-to-peer study, as well as we have this physician-to-physician warm line, which is not Project Echo, but it's a physician-to-physician warm line. We have an issue with uptake because of busy clinicians not being able to attend. But we also think that from a patient community standpoint, they just think it's absolutely normal for them to be dragging an oxygen tank around, 3 months after they had been in the hospital with COVID, and that's their new norm. And how do we get that health literacy out there is one of the biggest public health challenges, in my opinion.
Thank you so much for that answer. One of the questions that came up from our attendees here, and it's been answered in chat, but I think it'd be helpful, Dr. Orenstein, if you could just address it for the whole group to see, is related to any clinical or biological predictors of the occurrence or resolution of symptoms in long COVID. Can you please comment on that?
Yeah, based on some of the epidemiological studies from a variety of countries, we know that people that have hospitalization, that had a prolonged hospitalization, women, those that have multiple underlying comorbidities, they all seem to have a higher incidence of developing the symptoms of long COVID. As far as trying to figure out which ones go away, that's a bit more challenging. Again, there was a study published in the British Medical Journal back in January by an Israeli group that tried to look at which symptoms persisted versus those that resolved. And many of the common symptoms, some of the muscle aches and things like that, often did go away by 6 months. But some of the more lingering and problematic areas, such as the brain fog, the loss of taste and smell, those actually did seem to persist much longer in that group. Now, one would wonder whether the role of antiviral therapy in treatment as we move on in the pandemic might impact that. We don't know that yet, but that is obviously one of the things that we'd be interested in knowing, is that a lot of this data is coming from the early part of the pandemic, where we had the Wuhan strain, the Delta strain, and so forth. And we don't have as much data yet from the Omicron variants and whether some of these manifestations occur more commonly. And then we've been telling people that have underlying illnesses that they should be treated. So many of them have received either monoclonal antibodies or have received antiviral therapies. And perhaps that will impact how long these symptoms persist after.
Thank you so much. Another of our attendees has made the observation that it's quite difficult to kind of piece apart and differentiate diagnosis when you're looking at things such as memory complaints, brain fog, low energy. Is this long COVID? Is it a mental health comorbidity? Is there some physical etiology there? And that this struggle for diagnosis is kind of occurring across that clinical spectrum for PCPs and specialists. And then from there, how you treat that. Are there suggestions that you all have about kind of how to approach this as far as an assessment and treatment, Dr. Rowe?
Yeah, so one of the problems in the past was that if you came in with fatigue and of a substantial nature and brain fog and a few other symptoms, we were taught in medical school that must be a psychosomatic or somatic oversomatized presentation. I think what we are finding is that with orthostatic intolerance, when you're not getting enough blood flow to the brain, you're likely to have widespread multiple symptoms, but they're the same consistent group of symptoms, no matter where the patient is from. And so getting a sense of how people do when they're in quiet, upright postures is an important part of the history. We will ask, how do you feel when you're standing in line at the store? And our joke with the adolescents is that any kid who can't tolerate going to the mall has an organic problem until proven otherwise. But you'll find that they have to be out of there in 5 minutes. That's very unusual. We ask, how do you do it at church? How do you do it at any reception? Can you stand without feeling unwell and looking for the chair? And especially, how do you do, and this is important in Arizona, how do you do in the heat? And so one setting that combines both a heat stress and an upright stress is a shower. How do you do with a hot shower? Do you have to sit down in the shower or lie down afterwards? And every patient we see with prolonged substantial fatigue gets some form of an orthostatic test to look for this very treatable component of the illness. And that's usually a 10-minute passive standing test that anybody can do in their office.
That's helpful. Thank you. You all are so.
And I would add that, often treatment of the orthostatic intolerance is accompanied by improvement in brain fog and lightheadedness and energy. Not in everybody, and these are multifactorial symptoms, but those are among the things that we aim to address.
Thank you, Dr. Rowe. You're also orderly. Dr. Orenstein, we'll go to you next. Thank you.
Yeah, I was just going to comment about some of the things that Dr. Rowe had mentioned. So, in infectious diseases for years, we've had people referred to us for either chronic Lyme disease, chronic fatigue, and so forth, thinking that those individuals needed antimicrobial therapy. And what we find when we look at a large number of these individuals is that they all have orthostatic intolerance. And we often refer them to our colleagues who help them, to manage their orthostatic intolerance to their benefit, as opposed to giving them weeks or months of antimicrobial therapy that often offers no benefit. So I think that's really key. A question I actually wanted to ask to Dr. Rowe is, why do we see this so much in adolescents and young adults and less commonly in older adults?
Yeah, I don't think we have an answer for that. It is also very clear that we don't see it in younger kids. So there's something about hitting the pubertal growth spurt, and maybe it's the hormonal changes that come with that, that puts people at risk. Even the ones who have joint hypermobility had that from birth, but they don't present until adolescence. And you're absolutely right that from a lot of data, especially from Europe, there's a peak in adolescence and one in the 30s, but it doesn't keep getting more common as you get older. One point also about the brain fog is that in the ME/CFS, and I believe in the Lyme studies as well, the people who have brain fog often can sort of muster the ability to do well on neuropsych testing. But when you do functional MRI imaging, they are recruiting much wider areas of the brain in order to accomplish that task. When you do cognitive testing on them supine, they're fine. When you put them on a tilt table, they often start making mistakes or having delays. So there's this idea that the brain needs blood flow shouldn't be surprising in order to function properly.
Dr. Staub?
Yeah, so the other thing I'll say too, Bob, is I think as a practicing pediatrician, it may just be easier to recognize these long COVID symptoms in younger kids and in adults who are more surprised that they have those symptoms than what an older person might accept as just kind of, the symptoms following any acute illness. That was one comment. The other one was, looking at Dr. Rowe's slide with all the associated diagnoses with long COVID, and then thinking from a data perspective and a public health perspective, how do we track this? It is just so complicated, right? Because it's really hard to tease out, and all those other diagnoses tend, I think, to be easier in many ways to make than calling it long COVID. So from our perspective, when we're thinking about tracking this, if you don't have that long COVID designation, it's very hard to piece out all the other associated things, including, who are our disproportionately affected populations and how do we reach them. So, I'm really excited by the work that Dr. Parthasarathy described doing with SEAL. Public health is going to rely heavily on our partners who are out there and who are the trusted partners working out in the community to really give us a good sense of what this impact is. And I'm very glad that we've developed good relationships with those groups over the course of the pandemic, because it will continue to serve our larger understanding of this impact on the community.
Dr. Parthasarathy?
Yeah, I just wanted to tie, one of the questions that emerged in terms of, how do we distinguish that, these patients, what tests can we do? And I appreciate Dr. Rowe talking about this, simple screening test to look for, postural hypertension. But the other thing I wanted to mention is that in the Recur study, we have these questionnaires, and with thresholds based on T-scores, which is what we see in the general population. So these are adjusted for the populations to how much fatigue you're going to have. So there's the PROMIS fatigue scale. And then if you use the T-score of greater than 55 or 60, ideally it should be 60. But, if you go lower, you're going to get a ton of patients that are, end up having the diagnosis of fatigue. So you could use one of the smaller tools. You can do this orthostatics, administer that tool. But the hope is that the Recur study, in order to answer the question from Ms. Sadie Durton, is that it ties to how does your body change. And so there is discovery studies going on in what we call extreme phenotype analysis in the Recur study, where we take people with unequivocal long COVID. There are no ifs and buts about it, that they have long COVID, and unequivocally normal, because normals are also recruited into the study. Those were infected and are normal, as well as uninfected and normal. And then we are doing biomarker discovery to find out if you can come up with a blood test. And the reason why I mentioned that is that in terms of immune system changes that was brought up, is that autoantibodies are, as Dr. Orenstein mentioned, a key player here. And so using an antibody panel, but it's not just antibodies, it's the microbiome, it is the severe vascular damage to the organ systems. So there may be a composite amount of tests, just like we do cardiac risk prediction with a composite of 4 or 5 biomarkers. There could be a panel of biomarkers, but until we figure that out, it's going to be a while before we can come with a silver bullet test. You know, we're not talking treatment, but a silver bullet test, if that makes sense.
Absolutely. Thank you for that, Dr. Orenstein.
Yeah, so one of the things that I would comment about is that, you know, we are in a place in understanding long COVID similar to where we were in the early HIV epidemic. We didn't really understand enough about the disease, and we didn't really have specific testing or specific treatments. And so many people gravitated to whatever looked like it worked. I was telling my fellows this morning about, you know, how we used to give people a variety of complementary therapies to try to help them to cope with some of the symptoms they were experiencing, such as fatigue, weakness, fevers, things like that. And many of those are now being reintroduced into COVID-19. And I think it's going to be a period of time before we have a good enough understanding to have specific therapies beyond the symptomatic management that we currently have. So for people that are out there that are asking, oh, where do I send somebody? What do I do? You know, there are 2 approaches. One is to look at the symptomatic management of these issues, such as, you know, managing orthostatic intolerance. You know, there are many studies out there that help you to understand how to do that, how to manage fatigue, how to manage depression, and focus on those areas, but also consider referral to a study like Recover, because that's how we'll get the answers. You know, we'll get people into these studies, we'll have enough people to gather the information and then be able to pilot some of the things that may work. And I go back to the HIV example, we really didn't have anything, but we studied people epidemiologically for many years. But when products became available that looked like they might be effective, we then had a population that really wanted this. And we were able to get them engaged and study these and find out what worked pretty rapidly. Thanks.
Thank you. Thinking about, you know, the correlation with the early HIV epidemic and all of that, I'd love to invite Dr. Carroll to chime in a little bit about the Emerging Therapeutics Collaborative, how that relates here to COVID-19 and some health equity considerations as well.
Yeah, thanks, Jessica, and thanks to presenters and everyone today, and Dr. Staub from Public Health for a fantastic conversation on a topic that I think individually you could each speak to easily for an hour in your respective areas. So we appreciate the condensed format to this. But it ties to something that we'd like to share with folks in Arizona, which is a collaboration developing with some of the folks who are part of this presentation and rounds today, and others around the state, known as the Emerging Therapeutics Consortium for Arizona. Dr. Orenstein and Mayo Clinic, in collaboration with the Arizona Department for Health Services, have helped to build an initial foundation for this work, and we'll be collecting or connecting, as the right descriptor, connecting to the appropriate other folks and around the state to advise in a direction where timely information can be shared with all of you and with all of the clinical teams around Arizona about what we know. The good news is, as Sai shared and others, is there are things we know today. And of course, we want to get that information shared maybe before we close Sai, you could share again the PDP warm line, the peer-to-peer, so that clinicians can get assistance regarding acute treatment of COVID, but as well as how we get questions answered for long COVID. But this Emerging Therapeutics Consortium was born out of collaborative work that so many folks have been involved in Arizona and elsewhere. But the consortium will be building off the work around sharing information about monoclonal antibodies, be a collaboration between public health and healthcare delivery systems and care teams. And we'll be looking for ways that we can continue to learn together. So your ideas and anyone participating today are always welcome. Thanks. Thanks, Jessica. Thanks for letting me share that.
Thanks, Mark. If you don't mind, I was just going to show this warm line phone number, which is 833-937-1777. So if people are essentially within 24 hours, an expert in COVID and long COVID from infectious diseases, from allergy, immunology, pulmonary, neurology, and cardiology will get back to the provider. It's a provider-only line, and it asks for their NPI number, so it has to be a clinician that's placing the call. So I just wanted to share that number. Thanks, Mark.
And Sai, I goof with my P2P acronym. That's provider to provider. There's a separate peer-to-peer activity that you had shared. So my apologies for not getting my P2P activities. Maybe bring that up again for folks too, because I think that's important information.
Yeah, this is for patients, because as someone brought up, they commented about the fact that things are kind of in their head. They're made to think that it doesn't exist. So this provides both peer-to-peer support, shoulder to lean on, saying that you're not alone. There are other people like you who are suffering that. It's not in your head. It's a real condition. Here's a center of excellence that you can go see. Here is a research that you can participate in so that you can get your questions answered. And by the way, you could also be eligible for disability. So those are the four-pronged support mechanisms, essentially a peer support to revalidate their symptomatology, show them direction to both clinical care and research participation, and lastly, to be able to support them with their disability paperwork.
Yeah, thank you, Sai. I think so important for us as we are in the space of and discussing what we don't know, is being aware of what we do know, what the resources are, at least to connect both patients as well as practitioners and health professionals to folks to discuss circumstances, even if we don't have perfect answers. I know that that's helpful for all of us. Dr. Rowe, any quick comments as a fellow pediatrician? I have to take the last opportunity to ask you, just how do we break through this notion that adolescents are just not being adolescents when they're experiencing orthostatic intolerance, that these conditions are real? Any last concluding thoughts about that?
Well, it's true that the Japanese estimates are that 15% of healthy adolescents go through some degree of trouble with orthostatic intolerance. But I think the key thing is to look at the impact of it. And if you have orthostatic intolerance, it will often interfere with your ability to get to school. It's not that they don't want to be there, it's that they can't sit upright all day without lots of symptoms. So I think taking these patients at face value has turned out to be the main lesson I've learned in caring for people with these prolonged illnesses like ME/CFS and long COVID is they're not interested in making this stuff up. They really aren't.
Well said. Thank you all. Jessica, I'll turn it back to you for concluding remarks. Thanks.
Yeah, thank you so much, Dr. Carroll. A huge thank you to all of our panelists, Dr. Parthasarathy, Dr. Orenstein, and Dr. Rowe. This has been an incredible discussion that could have lasted all day. Dr. Staub, I'm very appreciative of all the work that public health is doing and all of your insights. For those of you who are seeking CEUs, you can use the QR code on the screen or the link in the chat to complete a survey, and we'll be following up on those CEUs. And please save the date for April 5th from noon to 1, where we'll be doing our next Arizona Community Grand Rounds on a collaborative response to the opioid overdose epidemic. Thank you all so much for your time today.